Hello, hello, everybody. All right, everyone's popping in. Good to see you all. Happy Tuesday. Welcome to our spotlight on swallowing today. I'm really excited to have this discussion. I think you must be too, because we had over 450 people plus register for this program today. So we anticipate quite a few people joining us. So we are glad that you're here. And if you want to note in advance, yes, this is being recorded, so you can access it later. You can watch it again. And I know there's going to be a lot of information provided today. Sometimes it's good to go back and review, slow it down, and take your notes. So we will make that recording available to you in the next day or so. While we are here today in person and live, I want to invite you to go ahead and open up your chat box, because that is where we're going to be asking our questions. And thank you to Ada from Cutler Bay for already giving us a shout out. So if you would also love to give us a shout out, we like knowing where people are joining us from, especially when we have so many people joining us. So it's always exciting to meet you and get connected with you this way. Even though we're virtually, it's fun to find where everyone is joining from. My name is Anissa with PMD Alliance, and I'm really excited to welcome our speaker today, Heather. She has been on some programs before, and she's one of our favorite speakers. She's part of the LSVT global community. She has done some work with us before talking about the Project Euphonia. So if you heard about that, that's an exciting project that we have shared with you before. Some of you may have even engaged in that study. But she's going to be talking to us today about swallowing issues. She is an expert clinician, training and certification faculty, and continuing education administrator for the LSVT Global. She specializes in diagnosing and treating dysphagia, which is the swallowing issues we see in Parkinson's and related disorders. So she's going to cover all of those today. We do welcome your questions. We're going to hold them until at the end, but we have saved some time for you to have those questions asked at the end. So please feel free to share them as she goes through things and it sparks a question. So I want to welcome Heather, and then I am going to push this over to you and let you get started.
That sounds great. Thank you so much for the warm welcome. Likewise, I just love coming and presenting with this fabulous group of professionals, this wonderful group of patients and family and caregivers. So I'm really delighted to be back today talking about swallowing issues in Parkinson's disease, and look forward to answering your questions at the end here. So I'm also loving in the chat seeing the variety of places that people are joining from. It truly is spread out, very diverse group, which is just fantastic. So what I'll be doing today is sharing my screen. I have a presentation that I'll be running through so that you can really see and hear how complex swallowing is, why it can cause problems, and then things we can do about it. The good news is we can be very proactive. And so let me get my screen share up. And oh, I see Traverse City, Michigan. That's one of my favorite cities. I saw that just pop up from the chat. So, all right, let me know if you don't see the PowerPoint presentation. I think it's all set. And I want to also be able to see my video panel so I can see folks' faces. So, all right. Well, as mentioned, I do work and consult with LSVT Global on a variety of projects. And I do have some biography information on my next slide. I won't go through it. Anissa did a wonderful job of sort of introducing my passion for swallowing, both in diagnostics and in treatment, as well as the projects I love to work with LSVT Global on. I will let you know that I do have a preference for the LSVT Loud treatment techniques. I am a paid consultant for LSVT Global, so I just wanted to disclose that financial and non-financial information up front. Today's talking points will really focus in on the what, why, and how of swallowing. We'll talk about function. What purpose does it serve? Beyond even just eating and drinking. Safety, that's a big one. We have to keep our swallows safe so that we're not aspirating items into the airway, into the lungs. And when there are issues happening with swallowing, we'll talk about the variety of implications this can have on health and quality of life for those living with Parkinson's disease. I also have a special segment dedicated to drooling because drooling and drool management, saliva management, are major factors in controlling Parkinson's disease symptoms that may affect us and our quality of life. Diagnostic and treatment planning with a speech language pathologist. And I'll talk a little bit about how a speech pathologist got involved in swallowing. Why does our profession look at that area of the body, and why are we the swallow experts for treatment and diagnostic? And then we'll talk about general recommendations to keep your swallowing safe. With any health-related recommendations, we know that there's never a one-size-fits-all fix for anything, and that includes swallowing. So thinking about swallowing, feeding, swallowing, they're really crucial for good nutrition, which of course affects our health, but they also are integral in protecting the airway when we're awake, but also when we're asleep, so that we're not aspirating food or liquid. Aspiration means food, liquid, saliva gets into the airway. We also know that swallowing is a very important aspect of social interactions, gathering for meals, gathering for a drink, a cup of coffee. It really is a social thing that we do with folks. And so it really is an important part of our social daily living. Much of our communication with family, friends, talking about your day, talking about events happening, talking about aspects of, at support groups, that often is done over a cup of coffee. So we want to make sure that feeding, swallowing, eating, drinking can stay that very social part of our everyday. So we can really think about swallowing, feeding as both basic bodily functions that we need for maintaining nutrition, hydration, overall health, but also to help us meet very important social needs. And so with this in mind, I want to point out that swallowing is a very complex series of movements, and these movements are coordinated by special neural circuitry, particularly in the brain stem. And feeding and swallowing are often broken down into phases or stages. We know that when we're eating and drinking, the movement from our mouth all the way down our esophagus to our stomach, it's continuous, and often these phases overlap. But you'll see in your medical charts, if you have ever been diagnosed with a swallowing issue, or you have an exam of your swallow and the lingo mentions the phases of swallowing, I wanted to point out these phases to you so you have a better understanding of what these clinicians and physicians are looking for. So I mentioned these phases by name, and I'll have diagrams coming up in the following slides so that you can also know how it may affect treatment if you need swallowing intervention. So let's talk about what happens when we're swallowing. We begin the process by getting food or liquid just into our mouths. The process of getting food and liquid in the mouth depends, of course, on coordination, whole body posture. If we're not in a good posture for getting items into our mouth or drinking, that can affect how we swallow. If need be, all of these aspects, how to get an item from the cup or the plate into your mouth, if those need intervention, we often consult with or rely on occupational therapists and our relationships with them. Now, I'll talk about more specifically for today is once food, liquid, and saliva are in the mouth, and what happens there. The very first phase is the oral phase. So this is going to be biting, sipping, chewing our food. It also includes forming that food, liquid saliva into a glob. That glob is called a bolus, but everyone understands what glob is. So I'll talk about the glob that's created. We want that glob of food or liquid to be cohesive so that we're not leaving little bits of food or liquid over in our cheeks or on the roof of our mouth or in our teeth. We want it all swallowed and cleared down. And the last thing that happens in the oral phase of swallowing is our tongue, our palate, they're going to help move that glob to the back of the mouth so that it's ready to be swallowed. So this picture here, it has slides 1, 2, and 3 for each picture. Really, this first slide on the left, slide number 1, shows that oral phase. This person is eating something green, so probably some vegetables, we'll say, and it's entered into their mouth. As they are chewing and manipulating that food into a glob, I want to point out something happening in the throat. So in the throat, toward the front in this diagram, there's a little white structure, and it sort of looks like this, if you can see my hand. It's up and open. This is the epiglottis, and this cartilage is what is integral in closing our airway, so things go down the right way. As you notice, this person with a mouthful of vegetables, their airway is open. And this is true for any normal swallow. This is why when you are chewing your food, you're able to breathe, you're able to talk, and that's because your airway is open. This is also why when we're young, our parents say, don't talk with your mouth full, because if we are talking, breathing, as we're chewing up our food, if we're not being coordinated with it, something can easily go down the wrong way. So there is wisdom to that advice that our parents gave us and that we give our children. Don't talk with a mouthful of food. The airway is open. Now, in the second part of the swallow, this is the throat phase. On a medical chart, it would say pharyngeal phase, but we can think of it as the throat phase. This starts once that vegetable that this man is eating, once that food gets to the back of the tongue, automatically the throat phase is activated. This is a series of really rapid events that moves the food and liquid through the throat to the esophagus and ultimately to the stomach. As the food moves towards the esophagus, it goes through this area in the throat that is shared between breathing and swallowing. So this is a really critical part of keeping our airway safe. Food and liquid have to move at the right time and be coordinated with the closure of that airway, that pause in breathing so that the airway is protected. So here you see that the green vegetables going down the throat, and now that little structure, that little, I call it the trap door when I talk to my patients, now it has flipped over the airway. The airway's in the front of the throat and the esophagus is in the back. So the diagram on the left shows things going the right way, the airway's closed. That's how it's supposed to look. If something goes down the wrong way, which we've all had happen, we've all choked, we've all said, oh, went down the wrong pipe. That's occurred with everyone at some point or another, but we get concerned when it's happening regularly, that trap door is not closed, and now you see that drip of green going into the front of the throat, which is the airway, the trachea, and that's when that airway has been compromised, and you're risking that food or liquid getting down to your airway and being aspirated. The third phase is the esophagus phase, or esophageal phase. This is when the very top of your esophagus, it's a sphincter muscle. And when we're not swallowing, that sphincter muscle is closed. When we are swallowing, it opens up, lets the food and liquid through, and then there's a series of waves of muscle contraction that the esophagus goes through to get the food and liquid down to the airway. So difficulties at any phase of swallowing, whether it's getting food into the mouth, eating, drinking, chewing at the oral, the mouth phase, swallowing through the throat phase, or getting things into the esophagus, if there's an issue with any of those stages of swallowing, this is called dysphagia or dysphagia. You'll hear it called either one. And so that's what that means. Essentially, it's just a swallowing abnormality or a swallowing difficulty. Now, when we talk about swallowing, I want to talk about safe swallowing. So what is a safe swallow? First of all, a safe swallow is when food and liquid stays in the mouth and it's not dripping out of the mouth. The lips are able to close. We're able to chew without anything escaping. And then it's also safe when that food or liquid goes through the throat goes into the throat rather, without leaving any food or liquid behind in the mouth. And once it's in the throat phase, traveling down, it does not enter into the airway. And then it goes through the esophagus without any delay. There's no pause, there's nothing getting caught up, and the esophagus is moving as it's supposed to. Now, when we contrast that with the swallowing issue with dysphagia, dysphagia can include not chewing our food well enough. Getting well-chewed food is actually the first stage of digestion. So it's really important that we chew our food well so that it's easy to transport it on down. Swallowing issues also include food or liquid falling out of the mouth or getting stuck in the mouth when we try to swallow. Certainly, if you ever get something stuck in your throat, there's different little pockets, there's little sinuses in our throat, but also things can get stuck in that top of the esophagus. So if something gets stuck in the throat, that's an issue. And also, of course, if it enters into the airway, that's going to be an issue as well. That's not a safe swallow. And then, as I mentioned too, with the esophagus, it should be this nice wave of contractions, getting food and liquid down to the stomach. But sometimes there's a restriction or an esophagus isn't moving as strong as we need it to. And something can get stuck further down in that last phase of the swallowing. And specific to Parkinson's disease, I'll provide more details in a few slides here because there are certain aspects of Parkinson's disease that can affect dysphagia more prevalently than perhaps someone without Parkinson's. Now, some interesting facts about swallowing to break up the anatomy and the physiology that we just went through. So the act of swallowing is also called deglutition, and the act of chewing is called mastication. And for something to be to travel from the back of the mouth to the stomach, it takes about 2 to 9 seconds, depending on how thick or how big that item was. So it's pretty fast. And it involves more than 30 different nerves and muscles at work. It truly is a complicated action that we're doing. Another fun fact that I like to point out is the Adam's apple. The Adam's apple, when we swallow, moves up and out when we swallow. And that's that mechanism that helps that little trap door close. And yes, men and women have Adam's apples, but women's are smaller and you often don't see them. But for any of us, when we swallow and we put our fingers on our throat, we can feel a little bump moving up and outward. That's your Adam's apple moving and helping to anchor that trap door when you swallow. So kind of a fun fact. And gravity does help us swallow, but for a nice healthy mechanism, gravity is not totally necessary. Strong squeezes of the throat and the esophagus mean that we can swallow upside down. Someone in a really long handstand can swallow their saliva, for example, and it makes its way to the stomach, even when they're upside down, which is pretty cool to think and really neat to visualize how strong these muscle contractions are. And as I alluded to a few slides ago, when we say, "Ooh, something went down the wrong pipe," or "something went down the wrong way," that's accurate. That really is true. When food, liquid, saliva go into the airway instead of the esophagus, that really is that juncture between airway and swallowing that is so critical when we're swallowing. So that is a true statement. Something went down the wrong pipe. Now, how do we know if something is going well with our swallow or not going well with our swallow? Certainly there are symptoms and signs, and I'll highlight those for you, but there are also objective ways to look, because sometimes our body doesn't always trigger a cough, doesn't always swallow more than once to get things down from our mouth and throat if it's something sticky, for example. So ways to know for sure is by visualizing the swallow. How do we visualize it when most of our swallow is not visible, though? It's on the inside. Well, a speech language pathologist and other professionals can use clinical tests to see what's going on. Sometimes these instruments are used when there's a suspicion of swallowing issues, or when someone's been diagnosed with a condition that is known to have swallowing issues resulting. One example, and probably the gold standard example, is an X-ray exam. And it has a few different names, but it's basically an X-ray movie called a video fluoroscopy. And people in live time, in real time, they're eating and drinking different consistencies. And this occurs in a radiology department at a medical center. And this test is usually run by a speech language pathologist. And you eat and drink in real time while your swallow is examined. You're seated the whole time. There are other swallowing exams when you're drinking that you may be lying down or moved into different positions. That exam is a little different. That's an esophagram and looks really more at the esophagus phase, where this exam, the video fluoroscopy exam of swallowing, looks more at the oral, the throat phase, and some of the esophagus phase too. And so to show you what this would look like, this is an individual who is swallowing a banana. The banana has a little bit of barium on it so that it's visible, and you'll see it go into the mouth, get chewed up and swallowed. I'm going to play this a couple times. So there's the banana, they're chewing it, they're breaking it down, creating this nice glob. It goes to the back of the throat, and that's that darkness that you see because of the barium. Takes them a couple swallows to get it all the way down, which is okay. That's not abnormal. And you'll see, I'm going to play it one more time. The airway is in the front of the throat. It's kind of a lighter gray. And in this case, the banana stays out of that airway. It all goes down to the back of the throat where the esophagus is. So that's what the exam looks like. Now, the prevalence of dysphagia amongst the Parkinson disease population is around 80% of patients. So as we begin discussion of the relationships and impact of Parkinson's disease on swallowing, it is important to point out that there is not a direct relationship between how severe the Parkinson's disease is and if someone is aspirating, if something is going into the airway, particularly silently into the airway without the person feeling it, which means they don't cough it out as they should. So there's a big motor impact on swallowing from Parkinson's disease. This includes rigidity that can affect swallowing. Tremor can affect how we're getting food and liquid to our mouths. And then in of particular interest that we really see the effect is with the smaller movement that Parkinson's disease causes across the body and the slower movement that is caused. So the hypokinesia and the bradykinesia. We'll break each one of these down. So when we know the base of swallowing impairments across the swallowing phases, let's talk about why it's affected. So when there's slower movement, this is important because timing matters in swallowing. As I mentioned, it can take as little as 2 seconds for something to go from the mouth down to the stomach. And so that's pretty fast. And we need that swallowing timing to be right. So if the airway is not being closed in time, if the slower movement is having an impact on keeping food or liquid in the mouth or coordinating breathing and swallowing, we hold our breath. Not only does the airway close, but we also hold our breath in the middle of our swallow. And that esophagus, if the esophagus doesn't open and close in time, that can lead to feelings of, oh, I think something is stuck right here in my throat. I have to cough and get it out. So timing can affect all those factors. The smaller movement, the hypokinesia, matters for range of motion. We're dealing with a lot of neural networks and muscle networks in here. And so range of motion matters. We need it for chewing and forming that little glob into a really manageable piece to swallow. We need good timing also to keep food and liquid in the mouth. And that movement too. If we have smaller movement of our lips or our mouth, we're going to be more likely to have food or liquid escape. And also for the swallowing squeezing mechanism. Not only does our esophagus squeeze our food and liquid down, but the back of the tongue, these throat muscles in here, all squeeze to move food and liquid efficiently. So if our movement is smaller, that's where the impact can occur for keeping the swallow easy and safe. But the really good news with this impact is we know that exercise, including swallowing exercise, is medicine. We know that working out helps us, whether it's body workout, whether it's voice workout, whether it's eating, drinking, swallowing workout. Exercise truly is medicine. And we also have good news that early intervention matters. If we start addressing the smaller movement, the slower movement early on, we see that that really helps to keep things running smoothly longer. And when we do need intervention, that we're much more likely to have a positive response. Now, there's also aspects of Parkinson's disease that are not related to motor that can affect swallowing as well. So I'd like to mention these. Sensory deficits. Sometimes we're not feeling how something is moving in our throat. We may not feel that there's food or liquid that's sticking around. We might not feel the saliva building up in our mouths that later may lead to drooling. We also have the sensory impact on feeling like we're swallowing in a nice, normal way, but in fact, it's small and it's not efficient. Just like our voice, when we are speaking and it's quiet, but we feel like it's loud enough, or if when we're walking and we're taking small steps, but we say, no, it doesn't feel like I'm shuffling, that can be similarly impacted with swallowing as well. Reflux, and that may be diagnosed as GERD or reflux that comes up into the esophagus or the throat. Gastroparesis, just slowed movement of the intestinal system. Impacts may also include malnutrition and dehydration. Muscles work better when they're well hydrated, and our bodies work better when we're well nourished. So those can play an impact. And there may be apathy that can be developed over time about eating and drinking. And then perhaps we're engaging less in eating and drinking. and then the repercussions may follow. So really the bottom line is that dysphagia in Parkinson's disease has major repercussions and a multifactorial basis. So we see too, and again, I kind of touched on this, but this is worth revisiting, similar to what happens in Parkinson's disease, where a patient will speak quietly, but feel loud, or take small steps and not feel like they're shuffling. There is a known sensory deficit for those with Parkinson's disease. And over time, we see that smaller and slower movements might be perpetuated. They might be made reinforced and then made more significant over time because of this abnormal sensory feedback. And so this results for swallowing in decreased awareness. You may feel that your swallowing is fine, but your family members may notice, gosh, your voice sounds wet after you drink, or you're clearing your throat and coughing a lot during meals. There may be a lack of self-correction. I've had patients who say, oh yeah, something feels stuck here. And I'll say, well, did you swallow twice to get it down? And they say, no, I didn't. So there's that lack of self-correction. You know, everyone sometimes needs to swallow twice to get something down, especially for sticky consistencies. We see also that in Parkinson's, folks respond really well to something externally triggering them or cueing them. So a person saying swallow twice, or a sign that says swallow twice each bite, that we see that being more likely to produce the targeted behavior than the patient self-correcting. And they don't spontaneously maintain or adapt treatment techniques unless the treatment is intensive and it also has a sensory focus. It's not just enough to work muscles out. We also have to have treatment that addresses from a sensory point of view as well. These sensory changes that I mentioned can occur in less frequent swallowing, and that's really important for saliva management. If we're swallowing less, saliva is more likely to accumulate, and eventually it's going to slip out of the mouth and we're going to have more drooling. These sensory changes can also result in not clearing food and liquid from the mouth, little pieces that get stuck in the teeth or in the cheeks or even in the throat. We get sometimes the back of the tongue or the throat coated in food or liquid, and people aren't clearing that residue. And if you have residue in your throat, when you go after your meeting or after your meal rather, after meal times, if you have residue in your throat, you're up, walking, talking, breathing, you could breathe in particles of that residue. We also see the sensory impact having folks report more coughing, more choking on residue, or wow, I swallow or I choke and cough on my drool a lot, or things are slipping out of my mouth more frequently. And speaking of drooling, we do find in the research, drooling is commonly reported. There's a big range, but somewhere between 30% and 78% of people with Parkinson's report drooling as a result of their disease. It is now assumed, as researchers have looked into this, that the cause of drooling in Parkinson's disease is not because of hypersecretions. It's not overactive salivary glands like we once thought was the cause. Now it's really attributed to inefficient swallowing, not swallowing often enough, and can often be combined with more open mouth, just at rest, more folks having an open mouth versus a closed mouth, or more of a stooped posture. It's more likely that any saliva that we're not swallowing is going to come out that way if we're not in a good upright posture. So let's talk about what to be on the lookout for with signs and symptoms of swallowing changes. So this way, you as a patient or as a caregiver, somebody who's eating and drinking with somebody who has Parkinson's disease, can be on the lookout for these. We know that the biggest repercussion from a swallowing disorder is aspirating, getting food and liquid into the airways, which can lead to pneumonia. And that type of pneumonia is not going to be covered by a pneumonia vaccine, the pneumonia shot. This is something that instead brings bacteria into the airways that can then fester and cause aspiration pneumonia. So it really is something that we want to take seriously and can have, life-threatening results if it happens. So let's be on the lookout for these signs and symptoms and then talk about what to do. So the signs and symptoms, the clearest cut, of course, are when eating and drinking, someone is choking a lot, or coughing and throat clearing after a swallow. And this could be with liquid or with food. If during a meal you notice that your voice becomes wet, that tells us that not all of your liquid got past your throat. And in fact, it may be sitting right at or above your vocal cords, and your vocal cords are in your airway. And that tells us that it's likely been aspirated or at least penetrated into the airway where it's not supposed to go. If you're consistently noticing, I have to swallow several times to feel like my food and liquid get all the way down, that can be a sign that we need to address the sensory and the muscle component, the strength of your swallow. Now, if it's something sticky that this is happening with, and only something sticky like a really thick oatmeal or a really sticky pudding or sticky bread, dessert bread, that is probably less concerning. But if you're noticing it across many consistencies that you're eating and drinking, that's enough to warrant talking to your healthcare provider. If you are finding after you swallow that you really are having to dig with your tongue or toothpick, or I have to go brush my teeth afterwards because there's just so much food and liquid sticking between my cheeks or in my teeth, that is also a sign. Of course, if food and liquid are coming out of your mouth when you're eating or drinking, we want to address oral issues of swallowing, just like we want to address the issues with the airway and the throat structures and musculature. And frequent drooling. This, even drool going down the wrong way, we want to be careful with that because our mouth has bacteria in it. And so if we have drool that's accumulating, and if it's picking up particles of food and either drooling out this way, or sometimes if you change head position, it might then be falling to the throat, we want to make sure to stay on top of that too. As I mentioned, the repercussions from swallowing difficulty are many, and they definitely can have a profound impact on our health and our quality of life. We don't want anyone to have decreased joy from eating and drinking. It is a very social thing. Food and liquid can be comforting. It can be something that brings us great happiness when we get that treat that we've wanted. And so that is a major component that we want to address in treatment. Under eating or malnutrition, if you're finding that eating and drinking takes too much energy, get an assessment, talk to your doctor about that, because if eating and drinking starts taking energy away from us rather than giving us good calories to have energy, that's a concern for malnutrition. Embarrassment or social isolation. So that's where, gosh, I have meal times with people and I'm drooling, or I cough and I choke and it's embarrassing. I don't want to go to dinner with my friends. We want to keep eating and drinking a social component and not to have that embarrassment.
Like to say I was to pick up a prescription.
As mentioned too, the increased risk of lung infections. So when food or liquid enter the airway, sometimes it doesn't get coughed all the way out. And in some cases, food and liquid enters the airway and it's silent. That means that people are not coughing. It's not that something went down the wrong way. Food or liquid can actually go in silently without us feeling and triggering that. And that can then enter the lungs. Our lungs are going to create more mucus. It can cause more chest infections, congestion, and as I mentioned, aspiration pneumonia. Now, it's worth repeating that the really good news is that diagnosing a swallowing disorder and then getting into treatment and intervention to address the motor, the muscle, the strength, and the sensory deficits can improve things. And so this was one of my favorite aspects to treat in the outpatient hospital where I was for years, because it really was empowering and seeing, giving people back the joy of eating and drinking and making them healthier from a pulmonary standpoint was just absolutely gave you the good goosebumps. It was so rewarding. So if you listened to any of those signs and symptoms and thought, that sounds familiar, here's my recommended next steps. Any of those signs or symptoms, but also if you are having unexplained chest congestion or pulmonary infections, and they're not otherwise explained, you know, if it is chest congestion because you had a cold that led to a bronchitis, that's different. That we know why your chest was congested in that case. But if you are having these episodes of feeling chest congestion, coughing up a lot of mucus, but you're not ill, you're not able to otherwise explain it, or getting actual pulmonary infections without having a bug first, that can be a red flag too. So your next steps would be to talk to your physician and obtain an order for a swallowing evaluation. That X-ray exam that I talked about being the gold standard, most facilities will call it a modified barium swallow study, or just MBSS. You can jot down those initials. And these will look at your specific challenges and impairments. As I mentioned, swallowing is really complex. Then in Parkinson's, swallowing can be impacted for a multitude of reasons, and they're going to differ person to person. There's no one size fits all. Even if you are, you know, dealing with two patients that are the exact same age, have the exact same diagnosis, the exact same symptoms, when we take a look at that swallow on an X-ray, they could look very different from one another, and treatment is going to be specially tailored to each person. So that exam is really great because it's going to look at your specific function. And it's very dynamic. If they see an issue, right then and there, they're going to try different strategies with you. They're going to try maybe changing how large of a drink or a bite you take. Perhaps they have you swallow in a different way. They give you a cue for really activating your muscles, or they put you in a different posture to swallow. So it's very actionable, and it starts figuring out those good compensation strategies right away. And at the end of it, they determine what's the safest way for you to swallow, the safest diet. Patients sometimes will have to change the consistency of food or drinks that they are eating and drinking for the short term. It's usually not forever, but until they get things addressed sensory and motor wise, sometimes we alter the diet a little bit. And as I mentioned, not all swallows are the same. There's no two that look identical. And so recommendations will really be tailored. And most facilities will give you the results right away. So you leave that appointment with an actionable plan to get started with immediately after the study. Now, after you're diagnosed with a swallowing disorder, then therapy usually begins. And this is therapy with a speech language pathologist, looking because from the mouth down all the way to the breathing mechanism is part of the specialty area speech pathologists work with. That's where we got to know and we understand very uniquely and specifically all of the structures, the anatomy, the neural networks in this area that also impact swallowing. So swallowing therapy can include strengthening exercises. Sometimes it's improving coordination between when to swallow and breathe and hold your breath. So that idea of timing mattering for swallowing. If that's where they see the issue happening on your exam, they'll work with coordinating that. Muscle breathing, the muscle strength. We see sometimes the muscles for breathing also get a smaller movement, and that's where some folks have this inefficient cough, where something goes down wrong, but they can't cough it out. So sometimes breathing exercises are targeted. There will also be dietary considerations to making sure that you have enough energy for eating and drinking. Viscosity. Thin liquid moves very quickly down the throat, but a graham cracker or pudding move very slowly down the throat. Some people do better with one consistency than the other. Sensory components of what you're eating and drinking too. Something very flavorful is going to be a little more exciting and a little bit more input from a sensory point of view than something bland. And candidacy for free water. This helps to improve hydration. This is for folks who, when they are drinking, they're aspirating. It's also something that would be specialized for you. And I want to make sure to point out that swallowing therapy really should be motivating for a patient. And so anyone who may need swallowing exercises, I encourage you to talk to your therapist about eating and drinking items that are meaningful to you. So what I mean by that is if you're enjoying the food and the liquid that you are practicing exercises on or addressing your sensory system on, we see that meaningful stimuli in therapy is more salient. It's going to make you feel more engaged. Motor learning happens better when the item we're dealing with means something to us. And also from a neuroplasticity point of view, there's great research that shows any kind of therapy that addresses and uses something in treatment that is exciting to you. So in this case, something delicious, something that makes you feel good and comfortable when you're eating and drinking it or brings you joy, that actually goes better from a neuroplasticity, from a brain component. So if you are doing swallowing therapy and you're only having water, a boring cracker to eat, maybe a pudding that you don't even like the taste of, ask to bring in your own items or have a family member bring in items. Talk to your therapist about coming up with the stimuli together for you. Some tips for safe swallowing. These tips are general. It's not a blanket statement or a one size fits all, but these can be a good starting point to have general good swallowing behaviors. These are good tips as you await any potential diagnosis or treatment. So limiting distractions. If we have a lot going on and we're moving a lot and we're attending to a bunch of different things or multitasking, coordination goes down. So limit those distractions. Chew thoroughly. Really get that glob nice and ready to swallow. Start the digestion up here, not just in your stomach, and it's going to be easier to get down. Swallow one bite before taking the next. So we all have folks that we know. I grew up with brothers, and so it was very common for us to take a bite, start chewing it, take another bite before we even swallowed the first one. That's not great to do. That's not going to be a smart idea for our airway or our coordination. So really take the bite, chew it thoroughly, swallow, then put the next piece of food in your mouth. Same thing with drinking. Take one drink at a time. Swallow it all the way down before you take your next sip. Good posture. This is good for a multitude of reasons, but also for swallowing, because the way that our head position and our neck position are when we eat and drink matter for protecting that airway. So I just tell people to have a neutral head posture. Sometimes a therapist may recommend changing your head posture. I will lead that to your specific diagnosis and what they saw work. But as an overall statement, neutral head posture. Very cold, very flavorful food and liquid increase the sensory input, which can be helpful. Swallowing twice for each bite and sip, particularly if you're one of those that notice, oh, things are sticky in here. I'm going to swallow that bite and then I'm going to swallow it again. Be cautious with straws. For some people, straws work better. For some people, straws shoot things down too fast and it goes in the airway. So just keep an eye on straws if you are someone who drinks from straws. Staying well hydrated is good for us because it keeps our mucus thinner. If something does go down the wrong way, so to speak, it's going to be easier to cough up the mucus later if we're hydrated. And of course, keep monitoring that coughing and throat clearing when you swallow. In terms of drooling, I mentioned these tips separately because drooling can be separate from the oral and pharyngeal phase, the throat phase of swallowing. Here, I will also say optimize your hydration, and for a few reasons. One, when we're drinking enough water throughout the day, we're swallowing more frequently. And the more frequently you swallow, the more you are clearing your saliva from your throat so that it doesn't have a chance to lead to drooling. This also, as mentioned, makes secretions thinner, including saliva. And if saliva is thinner, it's easier to move. It's not going to be sticky or, you know, kind of create like a film on the mouth if it escapes. It's also great because when we're hydrated, it keeps our mouth cleaner. We're clearing out, we're flushing that mouth so that it's free of any food particles. Posture, avoid posture like this. We're more likely to have drool happening if we're letting gravity be on its side versus up here. It's harder for that drool to escape. And then there's this idea of dry swallows. So regardless of if you're feeling like, oh yeah, there is something building up, because our sensory system isn't always accurate, frequently get in the habit of just swallowing without food, without liquid, just swallow. So if any saliva started to accumulate, you're clearing it. Some people will have like a reminder to just a little ding on their phone. And whenever they hear that, they swallow so that they know they're clearing that saliva throughout the day. And so with this, I have just a couple notes on speech therapy and its relationship to swallowing. We know that voice and speech and eating, drinking, swallowing share the same anatomical structures. They both require activity and coordination across the breathing mechanism, our throat mechanisms, our mouth mechanism. And there is some degree of shared control neurologically in our neural bases for these very diverse, very complicated behaviors. We also know that rigidity and bradykinesia will impact voice and speech as well as the oral stage of swallowing. And those issues with how we're scaling our movement. Movements get smaller in Parkinson's disease, the sensory motor integration is impacted, and that's why both voice, speech, and swallowing are affected. A variety of behavioral treatments have been used to improve Parkinson-related swallowing deficits, but very few have looked at can voice and speech therapy address and improve swallowing. And what we saw in our research with LSVT Loud is there were some improvements in swallowing after voice therapy, which was sort of unexpected. So we dug into why. Why is that? Well, the target of LSVT Loud is on increasing movement, increasing amplitude, getting away from small movement. That's important for bradykinesia, rigidity, hypokinesia. LSVT is intensive. We know that exercise is medicine. If anyone's had LSVT Loud, you know that it is a workout. We're challenging the system. It's 4 days a week for 4 weeks. It's an hour of really engaging and fun exercises that are motivating. And so that high effort and addressing the sensory component to all this area shared with swallowing. So we see that that can have an overlap too. And in voice therapy with LSVT Loud, we are bringing people's sensory awareness up. We're improving it. We're calibrating people so that they know when they have small voices that even though their ear says it's loud enough, it's actually too quiet. And so we're rescaling, we're generalizing, and that's super important for addressing the swallowing sensory issues too. There's this great cross-system influence from voice treatment, where in voice treatment, the vocal cords come together. We know we need the vocal cords to also come together when we swallow. That's the breath hold. Pitch changes. When we change pitch, that Adam's apple that I mentioned earlier moves. And that movement during pitch changes also helps move when we're swallowing, and that's important. We also see that voice therapy through LSVT Loud is effortful, it's coordinated. And as I mentioned and have talked about, swallowing is complicated. We need good effort. We need that good coordination. So this is where this cross-system influence occurs. We see that LSVT Loud improves a lot of things beyond just getting the voice louder. We see that on PET scan data, it improves on neural imaging. We see more facial expression after LSVT Loud, better articulation, breath support for speech, no more hoarse or monotone voice. We see that quality improve. But we also saw in this article in the box, El Shakawi et al. And Miles et al. Improvements on swallowing, which was super cool. The first research looked at improvement seen after LSVT Loud in tongue function and how the tongue was moving from the front to the back, the tongue strength, and also how it was able to stabilize the little globs that we need to swallow. So those were some nice initial findings. And in the Miles et al. Research, we found that 8 patients who all reported on a self-assessment issues with swallowing, that 4 weeks after doing LSVT Loud, 6 people reported improvements. Now, one person remained the same and another one reported worsening symptoms, but it was pretty exciting to see that improvement. We also saw that upper esophagus muscle had improvement in staying open for large volumes of liquid to go down. And we also saw improvements in strength from coughing, which is important if something goes down the wrong way. It's very important for me to note, though, that LSVT Loud is not a replacement for swallowing therapy at this time, but instead, perhaps we look at it from this idea of optimizing coordination and strength through voice and speech treatment and swallowing treatment. And that way we're really treating the whole person. So for those folks who need voice and speech therapy and swallowing therapy, these are ways to prioritize treatment. I want to leave enough time here at the end for questions, but essentially some people address one aspect, either voice or swallowing first. Some people will address them at the same time with different appointments occurring in different sessions on a given day. So those definitely are options to discuss with your therapist to see what would be most appropriate for you. And with all this in summary, we know that swallowing is multifaceted in Parkinson's disease. We know that the bradykinesia, hypokinesia, the sensory changes are really the drivers of disordered swallowing. And that it's really interesting that the physiology for voice and for swallowing are the same and may impact each other. And there is preliminary research suggesting this cross-system interaction that may make treatment more efficient on both ends. That all patients with a swallowing concern or a diagnosed swallowing issue need individualized diagnostics and treatment, and that in that treatment, LSVT Loud is not a replacement for swallowing therapy at this time, but it may help components. So prioritize treatment as able and indicated when you need to address both voice and speech and your swallow. So I don't know if we have time for questions. I know some questions did come through, but I'm available if you guys have a couple of minutes to answer some questions.
We do actually, and I know that we're at the top of the hour, but if people are willing to stay on for a few extra minutes, I do want to go ahead and ask some of these questions because I think that they will benefit the majority. And if you don't mind, I'm going to unshare your screen, or you can, that way we can see everyone. So I want to start first just in regards to when someone should actually have a swallowing about in terms of in their diagnosis journey. So, and then, you know, do these only happen later stages, or actually is there something that could be happening early on?
There are sometimes things are happening early on, and we do see that the severity of Parkinson's it does not always match the severity of the swallowing disorder. So in other words, you may be someone who's been diagnosed recently, or perhaps you have more mild Parkinson's presentation, but swallowing wise, you may be quite impacted. And so that's where tuning into any of those signs, symptoms, indicators from yourself or the people that you're eating and drinking with. If you are noticing any of those issues, I encourage you to bring them up with your doctor sooner versus later. We know that getting in for intervention early actually results in people doing better longer between treatment courses. And we also see that exercise idea of it being medicine and drawing someone's attention to the things they need to adjust early really do go a long way to the long-term prognosis. So you can't start addressing it early enough. If you have any questions, talk to your doctor or ask for a consultation to a speech language pathologist who can better sort of dig into whether or not you're having an issue and if you need more diagnostics like the modified barium swallow study.
And then in regards to like stages, when someone's more advanced stages and they're not able to get out of the house to go to outpatient therapy, because if they do some of these, they're pretty intensive. Is there availability of this in-home through home care? And also kind of to add to that, where does like end of life and hospice care fall into addressing swallowing?
Great question. Yes, if you are unable to leave the house, or even if you are able to leave the house, but you have the availability or the option in your community to have a therapist come into the home, whether that's through a home health agency, or there are some therapists who work privately and will do home visits. Many of those private therapists do accept insurance, Medicare, etc. And I really find that doing therapy in the home is really meaningful. We're getting you where you're eating and drinking. We can do therapy at your dinner table. We can have the food and liquid available to us from your pantry or your refrigerator, so that we are, again, having the treatment stimuli, those items for you to practice exercises on that taste good, that are meaningful. It's going to go a longer way to engagement, motivation, compliance, and also this idea of neuroplasticity when we're motivated by our treatment. So I encourage that not just for folks who are more homebound, but if you are able to, in your community, find a therapist who does home visits, I think that's a great way to go.
And then there's some questions in regards to modified diets. So how do you, number one, do those and make them palatable? Yes. And then two, we had a question about thickener. Like, is there a better thickener that people can use for their liquids? And any thoughts on that?
Really great question. Whenever, if I saw a patient and I did a swallow study and I determined that they were not safe, let's say on liquids, particularly thin liquids, because they move so quickly, and we had to thicken their diet. I'll say along that line, number one, There's various products out there for thickening liquids. I find that thickened water for most people is the strangest thing to thicken, because water is water. When it's thick, it just doesn't jive with our brains of how water should be. So I do find that a flavored liquid, when it's thickened, is more palatable. The gel thickeners that are on the market right now tend to be better tolerated by patients and taste better, or be tasteless is really more important aspect of that. The powdered consistencies they're getting, or the powdered thickeners, they're getting better, but some of them just stay a little bit grainy, and then that's not motivating. So I would look at some of the gel thickeners that are out there. There's a number of them that are very good. And it can depend on what's available at your pharmacy. Sometimes they're not widely available, but certainly if you have a thickener that you are not motivated by, let your speech pathologist know, and they can work with the different companies to help order it to your local pharmacy, for example, or put you in touch with one of the reps from that company to get it into your area, get it moved out, so that you have that option. I try to keep people on diet modifications as short amount of time as possible. So I really am digging into, when I work with patients, what do you want to eat? What's your, top 5 foods? What do you want to get back in your diet? Let's work towards those items so that it's meaningful, it's motivating, it's going to help your nutrition, it's going to keep your caloric intake up. And I also talk to physicians when it's appropriate for those patients who can't have water and need to thicken up. In some cases, there's something called a free water protocol, where you, and this is all discussed between the therapist and the physician, where you are given clearance to drink water, plain water, not thickened, but it must be outside of meal time so that you're not chancing flushing crumbs down with the water. You have to have a clean mouth afterwards. So there's some certain steps to it, but I really want to make sure my patients are not dehydrating. Dehydration leads to thick mucus. It leads to thicker consistency, drool, saliva, stickier throats. I don't want stickier throats. I want people well hydrated. So that's a component too that I would encourage you to talk to your practitioners about. It is in one of the slides. It says free water candidacy. I think it's one of the slides towards the top, but you can also just jot that note down. So it really helps with quality of life, but also keeping the system hydrated so you're not sticky.
And you answered a question about what the free water was. So thanks for explaining that. And that sticky throat and the drainage leads to the next question. So we have a couple that are tied to that. So is there anything with nasal drainage affecting swallowing? And then on top of that, I need to find it. Clearing cough and clearing your throat. How do you know if it's not sinus drainage versus a swallowing issue?
That's a great question. And then when we add on top of that too, sometimes coughing and throat clearing and mucus is related to reflux coming up. And reflux getting into the throat, or acid reflux can actually get all the way into the sinuses, believe it or not. It can travel all that way. And so there is a lot to parse out. And that's where really making sure that you're keeping track of your symptoms. So if you notice, wow, I get a lot of drainage after I eat a particular food, that might be a clue that perhaps that's a reflux food for you, and that some little bit of acids come up, not enough to make you heartburn or pain or get real burpy, but sometimes that's a sign that we've triggered some drainage up there. And you're right, if we are draining, we're going to be coughing and clearing more. So if you notice the timing of your coughing and clearing, is it within the first 20 minutes after eating or drinking? Then I'm more suspicious that things are not clearing the mouth or throat, versus if it's like, nope, I have it all day long, it's always drippy, it's always drainy, or gosh, it improves when I take, something for allergies. then that's a sign that it's more a sinus issue and less of a swallowing issue. So I would just say, if you're having those concerns, you're not sure where it's stemming from, try to jot down specific notes. When it happens, how is it related to what you ate or drank and the timing of that? And did you have any burping, heartburn, indigestion? Did you wake up with such horrible reflux and then the next day you're really draining and drippy? That might be reflux that got to your sinuses while you're lying down. So you have to play a little bit of detective. And if you have any trouble deciphering what that is, just having those timelines written out can help your doctor or your speech pathologist to hone in and figure out what the etiology is.
Awesome. Excuse me. Well, I just want to thank you for, this was really in-depth and very helpful. I know we have gone over quite a few minutes.
I'm so
really
sorry.
appreciate you being willing to stay on, and for everyone that stayed on, for your patience and you're willing to give up your time. So I want to thank you so much. And just for those of you who are watching, who are still on, this is being recorded. The slides will be made available. So give it a day or so. We did drop a few links in there. So if you want to be able to refer back to those, if you want to save your chat, that will allow you to go back and review those links. And if you go to your chat box, there's those 3 little buttons and you pop that up and it'll say save chat. That'll save that to your device. And then that way you can go back and access those links. So I want to thank you so much, Heather, for this wonderful conversation. And we want to give you, our audience wants to give you the wave of gratitude in PMD Alliance style to thank you so much for this, your time and your expertise.
Thank you so much. I apologize for going over, and thank you for those who could stay on. And for those who couldn't, I love that you have it transcribed and available after the fact. So as you can see, it's a passion of mine. I can go on and on. So thank you so much for having me.
Well, it was all wonderful information, and we had more questions that we didn't get to, so we'll just have you back.
That sounds like a great plan. We can have a Q&A session.
Right, exactly. Well, thank you very much, and everyone have a great rest of your day. Take care.